are healthy, have no medical conditions. On physical examination, the infant is lethargic with dry mucous membranes and generalized hypertonia. Which of the following should be restricted from the infant's diet? All right, so there is this 3-day-old boy who was brought to the ED due to vomiting, feeding, and progressively worsening lethargy. The parents report that the diapers have a sweet smell, very, very, kind of like they gave you a buzzword, sweet smelling diapers. Okay, what does that mean? What is that a hint of?
I think they are basically talking about
Syrup.
leucine, that some amino acids are not absorbed in the
Yeah.
body. So that includes 3 amino acids: the leucine, ornithine, and third one was, I think it's with B,
Isoleucine. Third one is isoleucine.
isoleucine. Yeah, maybe. I th- may, so I think
Leucine, valine, and isoleucine.
yes, leucine, isoleucine, valine, and maybe it was called as the maple syrup urine disease or something else.
Okay.
Yes.
Remember correctly.
So it's B. We all
Yeah.
agree with B.
Yes.
All right. Okay. Yeah. So again, whenever they say that the infant had a sweet smell, they're most likely referring to a maple syrup urine disease. Can anybody tell me what is the exact mechanism that there's a deficiency? Anyone?
Actually, the all this branched amino acid, they cannot enter to the Krebs cycle, and their excess definitely appears in the urine, and with air they don't no, this other one that much, and they cannot enter to the Krebs cycle. That's why they excreted by the urine with. And valine is have a smell like fruity smell. Yeah.
Yeah. So what's basically happening is that there is a blocked degradation of the branched amino acids. There is isoleucine, leucine, and valine. And why? Because there is a decrease in the branch chain alpha keto acid dehydrogenase, right? So this branch chain alpha keto acid dehydrogenase is very high yield in terms. You need to remember that there is this, a decrease in this enzyme, and that is why this disease is occurring. Again, if there is a decrease in alpha keto acid dehydrogenase, what will happen? There will be an increase in the alpha keto acids in the blood, right? And specifically leucine. And that is why you do treatment is basically the restriction of isoleucine, leucine, and valine in diet. Plus, you also give thiamine supplementation along with that. Try to remember that as well. The infant will present as vomiting, poor feeding, urines will smell like maple syrup or like of burnt sugar. Again, one thing I would like you to remember that in chronic conditions, it will cause a neurological decline. That is again the high yield pattern. And if you kind of see over here, they again say that it branch chain keto dehydrogenase, keto acid dehydrogenase enzyme. It is also neurotoxic. What type of disorder is it? Is it autosomal dominant or recessive?
Recessive.
Recessive.
Most of the enzymic disease, they are recessive.
Very good. All right. Okay. All right. Next question. They are concerned about the chance that their offspring will be affected by the disorder. Okay, so what's basically happening? They're offered genetic screening because they are of Jewish descent. The test result shows that the both are carriers for a lysosomal enzyme deficiency disorder that results in decreased metabolic degradation of a phospholipid substrate to ceramide, which leads to a buildup of the phospholipid. All right, what's happening in this?
It's a lysosomal storage disorder.
Yeah.
And I forgot the exact one because they are also get mixed up.
Fabry's disease. Can it be Fabry's disease?
It can be, like, it's definitely not A because that corneal clouding was that other disease. It was not
Yeah.
that. And coarse facial feature and cardiac dysfunction, maybe, but I don't think so.
Eliminate.
And
It's retinal opacification, actually.
yes, it's possible splenomegaly along with retinal opacification.
In what?
So,
In the Niemann-Pick disease,
No, it's a neuropathic pain and angiokeratopause.
What is happening in Fabry's disease? So basically, it is a triad of episodic peripheral neuropathy, angiokeratomas, and hypohidrosis. What do you mean by hypohidrosis?
Hypohidrosis means less sweating.
Very good.
Mm.
What enzyme is deficient in Fabry's disease? Alpha
But
galactosidase.
I know that in Jewish this substance used this genetically definitely the running is Niemann disease. But this biochemistry, this topic is very difficult for me. I always confuse
It's
between
okay.
enzymes
So the
and
deficient enzyme will be alpha galactosidase A. The accumulated substrate will be ceramide. What ceramide trihexoside? I think, if I
That's
recall.
what I think it's D because phospholipid is increased. It's going to cause opacification of the retina and somehow splenomegaly, I think. But I don't know. I don't remember exactly which lysosomal storage disease.
All right, let us see if you're right. And yeah, you're right. So it wasn't okay. So what type of, it was Niemann-Pick disease. So I was wrong. You were right. Yes. Okay. So what is happening in Niemann-Pick disease? Can anybody tell me how do you differentiate Niemann-Pick disease from Tay-Sachs?
In Tay-Sachs, I think there is hepatosplenomegaly.
yes.
No, in Tay-Sachs there is no
in Tay-Sachs,
hepatosplenomegaly.
Yeah,
no
in Tay-Sachs there is
hepatosplenomegaly.
no hepatosplenomegaly, and
Yes.
Yeah, it's
Niemann-Pick
okay.
disease, there is
only
hepatosplenomegaly. Mhm.
Yeah,
and
exactly.
cherry red spot in both.
Very good. So you will see cherry red spots in both, except the only way you can differentiate is that Tay-Sachs. That means that there is no hepatosplenomegaly, whereas in Niemann-Pick's you will see hepatosplenomegaly. So again, two important things: neurodegeneration, hepatosplenomegaly, along with cherry red spot and macula. They are very high here for Niemann-Pick disease, whereas in Tay-Sachs you will see the neurodegeneration. You won't see any hepatosplenomegaly, but you will also see cherry red spots on the macula. All right. Niemann-Pick disease is what enzyme is deficient in that?
Sphingomyelinase is in there.
think sphingomyelinase
Sphingomyelinase. Very good.
is
What
deficient
about-
in Niemann-Pick.
What about Tay-Sachs?
In the Tay-Sachs, that's the
It's hexosaminosidase.
Very good. Hexosaminidase A. All right. What are the accumulated substrates?
Mm.
What is the accumulated substrate in
phospholipid gets accumulated in the Niemann-Picks.
yeah?
Phospholipid and rest
What
I don't
about in
remember.
Tay-Sachs? GM2
No.
ganglioside? GM2 ganglioside?
Mhm.
Right. All right.
Okay.
Fabry's, I already discussed that. I was wrong. It wasn't Fabry's. It was Niemann-Pick's disease. So good job, whoever fought with me with the retinal pacification and splenomegaly. Again, Fabry's has a triad of episodic peripheral neuropathy, angiokeratomas, and hypohidrosis. What about Krabbe's disease? What happens in Krabbe's disease? Can anybody tell me?
Something related to CNS, like
Yeah, we have peripheral neural.
It is the a degenerative neurological disorder that affects the central and peripheral nervous system.
So you have peripheral neuropathy. There is a destruction of oligodendrocytes that are occurring. There can be a developmental delay. Sometimes there's also cranial nerve 2 atrophy. and the deficient enzyme will be galactocerebrosidase. And of course, when you don't have galactocerebrosidase, then galactocerebroside will accumulate. All right. What about Gaucher's disease? What happens in Gaucher's? They love to test you on Gaucher's disease. It's a very high yield disease. What happens in Gaucher's?
Is
Medical
pancytopenia, and the histological appearance is the crumpled tissue paper appearance of the macrophages.
Very
and
good.
there is avascular necrosis.
Glucocerebrosidase is
Fatty,
a
yeah.
Glucocerebrosidase. Very good.
And fatty substances are built up in liver, spleen, and the bone marrow.
Very good.
Yeah, it's gonna cause
All right.
osteoporosis.
Very good. What about metachromatic leukodystrophy? What happens in that?
It's also central and peripheral.
Demyelinating disease that damages the myelin covering the nerves.
Yeah. So there is a central and peripheral demyelination that occurs in metachromatic leukodystrophy. The patient can have ataxia, dementia, both of that. What is a deficient enzyme? Aryl sulfatase. And what will be the accumulated substrate? Cerebroside sulfate. All right, very high yield. Two other things that I want to discuss over here, hunters and hurlers. Let's do those two as well. What about hunters and hurlers? What happens in both of them? Can anybody tell me just fast? I've got only 30 seconds. Fast.
The main difference between them to remember is the lens opacification. It will occur in the hurler, but not in the hunter.
Very good.
Yeah,
And
this is the only
hunter
difference
are the
between one.
aggressive behavior one.
Very good. So hurler has a clouded cornea. Hunter does not have any corneal clouding. Again, hunter has an aggressive behavior. So try to remember that hunter needs to see in order to hunt, right? So that is why there is no corneal clouding in hunter, whereas in hurler you will see corneal clouding. Hunters are generally more aggressive because they're hitting the animal. So aggressive behavior and no corneal clouding, that represents hunter. The two enzyme deficient are different. For hurler, that is what?
Alpha iduronidase.
Yeah, very good. What about hunters?
It's iduronate to sulfatase.
Very good. And what will be increased in both of them?
It's
Heparin
going to
sulfate.
be dalmatan sulfate and heparin sulfate.
Very good, guys. All right, next question. Height is the 95th percentile for age. Weight is 80th percentile. Examination reveals sparse growth of long pigmented hair at the base of the penis and in both axilla. Testes are present bilaterally. Laboratory assessment reveals high serum concentration of 17-hydroxyprogesterone and testosterone. All right, so there's this 4-year-old boy, who's brought to the clinic because, the boy was developing pubic hair. He is also very tall, and the weight is also really high. He also has a body odor after he runs or plays. Okay, what's happening?
It's precocious puberty.
All right. What is the answer?
It's the A1.
Yeah, adrenal cortical hyperplasia.
Yeah. Called adrenal hyperplasia, and the deficient in 21 hydroxylase enzyme deficient.
Yeah, 21, because there is 17 if increased. That
Yes.
means yes, there is a deposition of 17. There is deficiency of 21.
Very good, very good. Again, so whenever you see 17, most of the times they're referring to 21. Not most, all of the times they're referring to deficiency in 21 hydroxylase. It is form of congenital adrenal hyperplasia. They love to test you in 21. Sometimes it tests you in 17 hydroxylase deficiency. 11 is the least tested. They don't test you on 11, but you need to be very familiar with 11, 17, and 21 and what's happening in three of them regarding congenital adrenal hyperplasia. They love to test arrows in all of them. What's happening to the sodium concentration? What's happening to the blood pressure? What's happening to aldosterone? What's happening to angiotensin? So they love to test you in terms of arrows. So try to remember that, and what increases, what is decreasing. if a certain enzyme goes deficient. So you should, there's this chart present in first aid regarding 17, 21, and 11 hydroxylase deficiency. Try to go through that thoroughly and make an image in your mind, because they love to test you on that. All right. Okay, so there is enzyme deficiency severe. How will 21 hydroxylase deficiency present? What's going to happen to the sodium concentration and the sex hormones? Can anybody tell me?
Sex hormones will be increased.
Very good. What about sodium?
Sodium wasting.
Sodium will increase.
Hyponatremia, self-esteem.
So sodium will
Hyponatremia.
increase or decrease?
Increase.
Increase.
Sodium will decrease.
Very good.
Decrease.
So there is this, I used
Decrease
to,
of mineralocorticoids.
yeah, so I used to remember it like this, that 21, so a guy who's 21 years old and
Yes,
who's
crush
going to
with it.
college, and so basically he's if a guy who's 21 years old is going to college, and that means he is old enough, so his sex hormones are very high, and he's not salty about it because he made it to college, right? So sodium will automatically go down, testosterone or sex hormones will go up. Because the sodium is down, as a result, the blood pressure is not going to be high as compared to 11 and 17. So, sometimes BP is a very big giveaway for 21 hydroxylase and 17 and 11 as well. First, whenever you see any sort of congenital adrenal hyperplasia, try to see the blood pressure. Because if the blood pressure is down, if that means, or it's normal, most likely they're referring to 21. All right. And if it is kind of deranged, then that means you're either talking about 11 or 17. Okay. All right. If you kind of go down, that's exactly what we talked about. All right. Next question. After initial assessment, appropriate interventions are initiated. Targeted suppression of which of the following hormones? All right. What do we do to limit androgen overproduction?
We have to decrease the ACTH, because the ACTH is the most this is the
So this was the chart I was talking about. So this chart is very, very important. They gave this similar chart in my exam, and they were like, okay, they put an X over here, and they were like, oh, what enzyme is deficient over here? So that is why I'm saying that you need to kind of thorough it in your brain, because they love to ask you this. So over here, that's 17 alpha hydroxylase. Over here you have 21, and so this is aldosterone, cortisol, testosterone. Again, very high yield chart. If you kind of go down and see that, we know that the treatment for CAH involves low doses of exogenous steroids. Why? Because they suppress the excess ACTH, which reduces production of androgens by the adrenal cortex. Okay. All right. Next question. FNA biopsy shows cluster of cells with large overlapping nuclei finally displays chromatin. All right. That is very pathognomonic. What are they talking about? Clusters of cells with large overlapping nuclei containing finely dispersed chromatin. Intranuclear infusion bodies are also seen. Which of the following is a diagnosis? So TSH is normal, everything, blood pressure okay, pulse kind of okay, hypoechoic thyroid nodule, increased central blood flow, okay, very easy. What's happening?
Okay, we will exclude it. In anaplastic, there is a difference. Now there is no capsule and no differentiated cells. Colloid nodules, no, there will be amyloid. Follicular adenoma, meldinous calcitonin, that's everything's normal. No small body is not mentioned in the system.
All right, so what is the answer?
Papillary carcinoma.
Papillary carcinoma. All right. Okay. All right, yeah. So, there are again four main types of primary thyroid cancer. Papillary carcinoma is one of the most high yield cancers of thyroid. Love to test you on. Again, intranuclear intrusions, very pathognomonic for, papillary thyroid cancer. That is why I always say try to go through pathoma again and again, because those lines that show up on your exam day and also in UWorld, and they're very, very high yield. So if the more number of times you revise it from pathoma, the more likely they're going to stick along with you. All right, again, overlapping nuclei, orphan ani nuclei, there are nuclear crews, intranuclear intrusions, there are also Samama bodies. What else? And what other tumor are Samama bodies found? Can anybody tell me?
This meningioma and
Serous.
yes, ovarian epithelioma.
Ovarian.
Very good.
Yes, these two I remember.
Very good. All right. So that's what we talked about. Okay, medullary thyroid cancer. In what conditions do you see medullary thyroid cancer? What?
Is M2, this includes.
Very good.
Yes, 2B especially. There is morphine body appearance and pheochromocytoma and medullary carcinoma of thyroid.
Very good. How do you
And
differentiate between follicular adenoma and carcinoma on the basis of what?
The capsule will be
Adenoma has a capsule.
in the
And carcinoma has no capsule.
Very good. Capsular invasion, basement membrane invasion, anything that invades the basement membrane has now turned into cancer. If it is restricted to the basement membrane, then most likely it's a follicular adenoma. There is no treatment for follicular adenoma. You just monitor the growth of the adenoma, and that's it. If it invades, then you take it out. Otherwise, for follicular adenomas, it is strict. It's not advised, to kind of take it out. You just monitor their growth. All right. Okay. Next
And
question.
also I remember that there in adenoma and carcinoma we cannot differentiate on fine needle biopsy. We have to remove the whole surgical biopsy. Then we can diagnose this adenoma or carcinoma intact of the capsule.
Yeah, we use fine needle aspiration.
That's true. Yes. All right. Okay. Interestingly, before FNA, what do you do?
Can you ask again?
Can we the scan?
Thyroid ultrasound. Yeah.
Nuclear findings.
What else? Even before the thyroid
Say again,
ultrasound,
I
what do
can
you
catch
do?
this question.
Even before the ultrasound, what do you do? You check for what?
Centesogram.
No.
Laboratory tests.
That's very basic. So a patient comes to you with goiter. What are you going to do?
Thyroid function.
Genetic analysis to see the
Thyroid
patient have a
profile.
mutation
Very
in
good.
red.
Very good. Thyroid
Yes, sir.
profile. So that is usually the right answer in steps that, when they ask you that a patient has come to you, what are you going to do? So, patients just jump to, FNA or ultrasound, but that's usually the wrong answer. First, do a thyroid profile, and based upon if it is hypothyroid or hyperthyroid, then we do ultrasound or radionucleotide scans, and after that, we do an FNA. So, because whatever is invasive, it's usually considered as a last option. It will never be the first option on US, I believe. All right. Next question. On examination, the patient's length and weight are normal and he has no apparent congenital malformations. All right, which of the following is most likely cause of the patient's condition? So there is this newborn baby. He was born at 39 weeks gestation. His mother has no medical conditions. Okay, so the serum TSH is a little bit high. Serum thyroxine is below the normal range for his age. All right, so thyroxine is low and TSH is high. What's happening?
I think this thyroid dysgenesis.
Why?
Because if in ectopic place it's not properly function and cannot excrete the optimum T433, and on the feedback it increased PHS.
Yeah. So again, congenital hypothyroidism babies, not necessarily that you will find it in a newborn baby exactly. All right. The moment a newborn baby is found, you will, kind of find it. No. Why? Why are newborns usually asymptomatic?
Because they are protected by their mother's hormone, its clearance from their body.
Very good. Again, they are asymptomatic because there is placental transfer of maternal thyroxine, and so it takes a lot of time for them to deplete, and that is why over the period of weeks they develop hypothyroidism. What is the treatment for this, for congenital hypothyroidism? What do you do?
Levothyroxine externally exogenous.
Levothyroxine. Very
Yes.
good. So you give levothyroxine. What do you need to monitor in levothyroxine?
Better THS is the more sensitive test. THS.
Very good.
Mm.
All right. Okay. Next question. Physical examination reveals deficits in the bilateral temporal visual fields. All right. Extraocular movements are bilaterally intact, and there are no other abnormalities. Which of the following additional findings is most likely to be present in the patient? So there is this 32-year-old man. He comes because of vision problems. He has had, several near misses while driving. Okay, frequent headaches. Okay, what's happening?
This
Pituitary adenoma,
pituitary
yeah.
adenoma most of the time is prolactinoma.
Prolactinoma, yeah.
Yes,
Yeah.
the A will be decreased libido.
Decreased libido.
Where do
Because
you
in
see?
jaw, enlarged jaw, there is growth hormone. Excessive urination, it's diabetic insipidus. Heat intolerance, it's hyperthyroidism. Skin hyperpigmentation, it's if there is ACTH releasing.
Cushing's syndrome.
Yes, Cushing, yes.
Increased ACTH. Skin
Skin
thinning. Where do
thinning
you
also
see
there,
skin
Cushing.
thinning? Where do you see skin thinning?
It's in Cushing's.
Cushing also.
Very good.
Mm.
All right. Yeah. So again, because the patient was having bilateral temporal visual fields problem, again, most likely they were referring to prolactinoma. Prolactinoma, of course, when the prolactin is going to be increased, it's going to cause infertility in men and hypogonadism. In women, it's going to be causing the opposite. It's going to cause galacturia. And amenorrhea, again, sign of infertility in women as well. And that is there's this condition in gynecology that you might have heard. It's called lactational amenorrhea, right? And
Yes.
lactational amenorrhea usually occurs in women who are breastfeeding, and it's until 2 to 3 months postpartum. But unfortunately, most of the women now don't undergo lactational amenorrhea because of the hormonal imbalances that they're having, because of junk food and a lot of sedentary habits. So because of the up and down hormones that are going on within their body right now, a lot of women don't experience lactational amenorrhea, and they can get pregnant postpartum. All right. Okay. So if you see that there's corticotroph ACTH, if it's increased, it's going to cause Cushing's. Growth hormone is going to cause acromegaly gigantism, thyrotoxicosis. Gonadotroph, it's going to cause hypopituitarism via a mass effect. All right. If you kind of go down, how do you treat pituitary? How do you treat a prolactinoma?
Octreotide.
Give octreotide.
Yes.
Can
analog
followed by drug.
or surgical later.
Surgical resection
Harder
first and then drugs.
So there is this. First you do a CAT scan or an MRI, and after that you monitor the the size of it. If it is greater than 8 mm, you go for surgery. If it is lesser than 8 millimeters, then you treat for a medical management. All right. This is very high yield. They ask you that, so greater than 8 is gonna say it's gonna you do surgery, and if it is less than 8, then it's wait a second, guys, I'm getting a call. All right, next question. All right, okay. Physical examination shows a hypotonic infant with a large anterior fontanel, large tongue, and a reducible umbilical hernia. Very easy. Where do you see this? Very easy.
Hypothyroidism.
Congenital
Yes.
hypothyroidism.
Congenital
Congenital
hypothyroidism. Correct. Isn't
So what is the answer?
E.
Hypothyroidism.
Let's read.
hypothyroidism.
So this is why I say
Nice.
one line gives you the answer. You don't need to go through it. All right, if you kind of see it up, worsening floppiness, good baby who rarely cries, and their stools have decreased, everything is also decreasing. Most likely they are referring to hypothyroidism. All right, what happens in botulism?
Paralysis.
Botulism is the other disease. In mostly,
Diplopia.
yes. In pediatric, if they give the honey,
Spastic paralysis. Yeah.
Paralysis.
Descending paralysis.
Very good. Descending paralysis. Where do you see ascending paralysis?
is
Guillain-Barré
Guillain-Barré
syndrome.
yes, GB syndrome.
Guillain-Barré syndrome.
Very good.
Campylobacter,
All
there
right.
is most of the time the bacteria bug.
Very
After-
good. All right. Okay. So if you see hypothyroidism, again, congenital hypothyroidism, it should be treated with levothyroxine. You do diagnosis, increased TSH and decreased in T4. If you see the, clinical manifestations, everything is going to be decreased. So, heart rate is going to be decreased, temperature, lethargy, hypotonia, constipation. So the entire body functioning is going to decrease. In later terms, thyroid hormone deficiency causes neurocognitive problems as well. We are more concerned about the neurological problems that the baby is going to develop over time if we do not start treatment with levothyroxine. And if you see that over here, untreated diseases leads to intellectual disability. So whenever they ask you what is the most important factor that we are considering in hypothyroidism, just click on anything neurological. All right. They always want you to, kind of pinpoint your neurological problems affiliated with congenital hypothyroidism. All right. Okay. Next question. Microscopic examination of the tumor shows electron-dense membrane-bound secretory granules. Okay. And it's positive for synaptophysin, chromatin, and neuron-specific enolase. All right. Where do you see this?
Not the same.
Pheochromocytoma.
Medulla, pheochromocytoma.
Adrenal medulla.
See, intermittent. Why have I highlighted intermittent? Where do you see intermittent?
In pheochromocytoma, there is
Very good.
episodic or intermittent.
So what is the answer?
B.
B, adrenal medulla. Is the
So we discussed pheochromocytoma yesterday as well, red gene mutation. They love to ask you the mutations associated with pheochromocytoma. They are very high yield. Von Hippel-Lindau, red, NF1, again, because increased catecholamine secretion is occurring. Symptoms are headache, tachycardia, sweating, hypertension. Remember, you give phenoxybenzamine and what else? Phentolamine. Remember to give alpha blockers first, then beta blockers. Yeah. All right. Okay. And then you take the patient for surgery. Okay. All right. An intact adrenal gland is obtained from a donor cadaver, and a histological section of the gland is shown below. Cells from a specific part of the gland are indicated by the arrow. Okay. What does it look like? What is this as part of the portion of the kidney?
medulla, because it's the last layer, granulosa, then fasciculator, then rectus is medulla, look like medulla. Yeah.
Very
Adrenal
good.
medulla, yes.
Okay, these cells are most likely to be directly activated by which of the following substances? All right.
Acetylcholine.
ACTH. B.
Acetylcholine, A.
Again, very easy
Acetylcholine.
question. So this is
No.
zona
A, ma'am.
glomerulosa.
The first. Acetylcholine.
What is the wrong? Yeah, A, I told, yes.
Okay. Acetylcholine. All right. Okay. So this is a zona glomerulosa. This is the cortex. This is the radicularis medulla. Remember that so the chromaffin cells, we know they're modified in neuroendocrine cells from the neural crest. Where else do you see the chromaffin cells? We talked about this yesterday.
melanin excreting.
Very good.
Melanocytes also, and in the heart there are the cushion of the heart rate, and heart-producing disease also
Yeah.
there.
Good job. Very good. Again, they're stimulated by acetylcholine, and we know that acetylcholine released by sympathetic preganglionic neurons, and they in turn secrete catecholamines. And that is why when there is increase in catecholamines, that there's a tumor in the adrenal medulla that they're referring to, and that's a pheochromocytoma. Okay. Now, why was ACTH the wrong answer? Can anybody tell me why was it the wrong answer?
It's for the secretion of glucocorticoid hormone.
Yes,
Cortex.
management of the cortex hormones,
Yeah, for
like
cortisol.
as we
Cortex. Yeah.
aldosterone, cortisol, and gonadotropin hormones. They all excreted from the cortex.
Yeah, good job. All right, next question. The experimental animals are subsequently found to have decreased both production of epinephrine by the adrenal medulla and cortisol in the adrenal cortex compared with the control animals. Decreased activity of which of the following enzyme is most likely responsible for the lower epinephrine in the experimental animals? All right, so there's this group of investigators, and they're studying the regulation of catecholamine synthesis in response to stress. Subject rats are randomly assigned. All right, they undergo the resection of the pituitary gland. Okay, and the control rats undergo craniotomy without a pituitary resection. Okay, so the experimental animals are then found to have decreased production of epinephrine by the adrenal medulla and the cortisol from the adrenal cortex compared with the control animals. All right, what's happening? What's decreased? What's going to decrease?
I think the monoamine oxidase, maybe. Not sure.
Monoamine oxidase is the
No, phenyl.
enzyme that metabolize the epinephrine. There is two monoamine oxidase in the neural cleft.
Phenylethanolamine and methyltransferase is decreased.
Yes, look like this because the catecholamine is also enzyme present in the liver and in the nerve ending, also metabolize the PNRP, dopa carboxylase, dopamine. These are the synthesis of it's not
Dopa
dopamine.
to dopamine, yeah.
Yes.
And
inhibitory.
norepinephrine
Yes.
to epinephrine is PNMT.
Yes,
Yeah.
tyrosine hydroxylase is for also the
Tyrosine
part of that one.
hydroxylase.
Yes, look like F. We
F,
exclude.
yes. This is the answer.
All right, yeah, very good. Catecholamine synthesis, if I kind of zoom it over here, tyrosine converted to dopa, dopa is converted to dopamine, norepinephrine, epinephrine. So these enzymes are very important. Tyrosine hydroxylase, dopa decarboxylase, and then there's dopamine beta hydroxylase. Very, very important. If you kind of go down and you see this as well, we know that cortisol increases the conversion of norepinephrine to epinephrine in the adrenal medulla by increasing phenyl ethanolamine and methyltransferase. I used to remember it by P and M. So whenever I saw P and M, so I couldn't remember the full name, so I said P and M, the long one, or I used to say the long one. So because I couldn't remember the name, was too erratic. I don't know why. USMLE loves to test you. I mean, what are they gonna tell us? I mean, this just doesn't come up in residency. What's the purpose of it? But anyway. All right. Physical examination shows mild diffuse enlargement of the thyroid gland. Cardiopulmonary abdominal examination or normal biopsy of the patient's thyroid is most likely to show which of the following findings. All right. Okay. So there is 51-year-old woman. There's progressive fatigue, weight gain, constipation. All right, blood pressure is a little low, pulse is a little low. There are no drug allergies, no significant medical history, no medications. All right, okay, so she's having goiter and she's hypothyroidism. She has hypothyroidism clearly. All right, what is the most common cause of hypothyroidism?
Hashimoto's. The most common
Hashimoto's, so
cause.
it's intense lymphoplasmacytic infiltrate with active germinal centers.
Very good. So most common, whenever they ask you in terms of this, right, biopsy of the patient's thyroid or whatever, and they give you a picture, most likely they want you to know the most common, right? They don't want you to think, oh, it can be cancerous, it can be this, it can be this, all right? They don't want you to think like that. Of course, it can be cancerous. We don't know, and that is why we have to run the thyroid profile to see what's happening. But we should also be aware of that most likely whenever they give you a question like this, they want you to know the most commonly involved cause. All right. So that's there. Remember, Hashimoto thyroiditis again is associated because it's an autoimmune disorder. So it's associated with other autoimmune disorders. Autoimmune diseases go together. All right. So there is these hurtful cells that are also present, and anti-thyroid peroxidase antibodies are usually they're also elevated over here. And if you kind of scroll down again, so these are the pictures. This is the germinal center, lymphocytic infiltrate. These are the thyroid follicles. All right. Okay. Next question. After initial laboratory testing, a thyroid scan is performed and reveals diffusely decreased radioiodine uptake. ESR is high. Okay, I saw two things: decreased radioiodine uptake. ESR is high.
There is information.
Itis. Very good. What's the answer?
Acute thyroiditis.
It's D-querying.
All right, so the answer is what?
Look like D.
Yeah.
Mixed cellular infiltration.
It is multinucleated giant cells because
It's
it is a
Hashimoto,
inflammatory
the
condition.
E.
Yeah.
And the branching papillary structure with it's calcified is samoma body is papillary carcinoma. Extensive stromal fibrosis extensive beyond the thyroid. This thyroid follicular carcinoma.
Anaplastic.
Yeah, D. So.
Yeah. Okay. So if you kind of see, again, like I said, itis, ESR, most likely they're referring to dequervin thyroiditis, also known as subacute granulomatous thyroiditis. Initially, the patient will have hyperthyroid, and then, chronically, the patient will develop hypothyroidism. Over time, you give NSAIDs in this patient, treat the condition, that's it, it will go away. It does not have long-term consequences, but it can also have long-term consequences if it gets chronic. Then the patient is immune to developing hypothyroidism over time, but immediately if you treat it, then there are no consequences. All right, eye examination is normal. Oral inspection reveals several small, soft, flesh-colored papules on his lips and tongue. What does this mean?
Mucosal neuromas.
Mucosal, very good. Mucosal neuromas. Where do you see mucosal neuromas?
In men type 2B.
Men type 2B, yeah.
What else do you see aside mucosal neuromas?
Pheochromocytoma and marfanoid body picture.
Yeah.
Very good. So you see medullary thyroid cancer along with it, pheochromocytoma, mucosal, and marfanoid. Medullary thyroid cancer, we also see in type 2A, type 1 as primary hyperparathyroidism. Okay, so try to remember this way that most of the times that type 1 and type 2A, it can be both. But parathyroid adenomas are kind of linked to type 1, and parathyroid hyperplasia is linked to type 2A. So, if it's primary hyperparathyroidism, students just say, oh, it's primary hyperparathyroidism for both type 1 and type 2A. But USMLE wants you to be specific, right? So for type 1, you have parathyroid adenomas, and for type 2A, you will have parathyroid hyperplasia. Both will be cause of primary hyperparathyroidism, right? But they're two different causes, okay? Try to remember that. And again, so for type 1, you have 3 P's, right? Primary hyperparathyroidism, pituitary, and pancreatic. Pancreatic gastrinomas, they want you to be very specific about. Pituitary tumor, prolactin, they want you to be specific about. All right. Okay. Next question. All right. So you first see the labs. What is wrong in the labs? Can anybody tell me what's wrong in the labs?
Hyponatremia.
Iodine is decreased.
And decreased osmolarity, 250.
Yeah.
Okay.
Hyponatremia.
All right. Okay. So where do you see a decrease in the sodium and plasma osmolality? There's also a mass at the right side.
Yeah, and small cell lung carcinoma. the-
SIADH.
SIADH,
IRAH.
small lung cell carcinoma.
Small cell lung carcinoma, yeah.
Okay. Which of the following additional findings is most likely to be present in the patient? What's going to happen?
Euvolemic D, normal appearing volume
U.
status. Euvolemic.
Euvolemic. In SAD patient, euvolemic. That's why delusional there is hyponatremia.
So
Yeah,
this
normal
is
appearing volume status.
very good. So this is syndrome of inappropriate antidiuretic hormone, or SIADH. SIADH is, can occur with small cell lung carcinomas. What else can they occur with? What else can SIADH occur with?
Brain.
Trauma.
Very good. All right. So in any traumatic conditions, SIDH can occur. So if you see, any road traffic accident patients or, burns patients, it can trigger
Several hemorrhage, also with the drugs. Drugs like
Even a stroke.
carbamazepine.
Pneumonia, tuberculosis.
pneumonia,
Yeah.
tuberculosis, very good. All of it can trigger SIADH. So what's happening is, because there's excessive ADH secretion, it's causing water retention. And when there is water retention, it is increasing the total body weight, total body water. If there is increase in body water, what's going to happen? The sodium is going to get flushed. Sodium is going to get diluted.
Get diluted.
Right?
Yeah,
There's
hyponatremia.
dilutional hyponatremia that's occurring, and because there's dilutional hyponatremia, you have euvolemic hyponatremia because the volume isn't lost, right? There is increased total body water. The volume is there, right? But why is there sodium less? Because it has been diluted in the excess water, right? So if you see over here, this fluid volume expansion, decreased aldosterone, you see over here, increased urinary sodium excretion, further sodium loss. So how do you treat euvolemic hyponatremia? Can anybody tell me?
Water restriction.
Water restriction.
There's
We give the
antidiuretics.
Dementia. ADH.
ADH analogs are given tolvaptan kind of drugs.
Water and sodium restriction.
All right, yeah. So exactly. So this is what is happening in this. I'm sorry, I missed the entire point. I was on call. What was the treatment for euvolemic? What did you guys say?
ADH analogs are given, diuretics can be used, and hypertonic saline can be used. These kind of things can be used.
Again, okay, very good. So first what you do is fluid restriction, right? Because there's a lot of water retention already occurring. What you do is, number one thing, you fluid restrict the patient, right? You fluid restrict the patient. After that, you need to identify the cause. What is the cause? There can be, a lot of causes such as hypothyroidism. It can be adrenal insufficiency as well. It can be certain medications or other medical conditions. So the first immediate treatment is to fluid restrict, and then kind of try to find out the cause. You can give loop diuretics. You can give, vasopressin receptor antagonists such as tolvaptans as well, right? But the first thing is you fluid restrict the patient. Okay. If you kind of go down, again, it's a perineoplastic effect secondary to small cell lung carcinoma of the lung. We knew about that. All right. Okay. Where do you see hypovolemic hyponatremia? Where do you see hypovolemic hyponatremia?
Diabetic insipidus.
Very good. What about hypervolemic?
Hypervolemic is hypervolemic. In SCD, we can see the hypervolemic, yes. There is going to be this psychogenic polydipsia. There we can see hypervolemic hyponatremia.
Hypervolemic.
Hypervolemic.
Yeah.
Yes, ma'am. Then this patient is psychogenic polydipsia, means psychogenic.
Liver
Or
disease.
it can be two high yield causes: heart failure, cirrhosis. Heart failure.
Yes,
What
heart
are you seeing in heart failure? You're seeing a fluid overload over there. So that is hypervolemic, right? All right. So that is hypervolemic. Over here, there is a water retention occurring. Over there, what is occurring in heart failure? There is this fluid overload that is occurring. Okay. So heart failure, cirrhosis, any sort of kidney disease, nephrotic syndrome, renal failure, you will see hypervolemic hyponatremia. Okay. Hypovolemic hyponatremia and any sort of, GI losses such as diarrhea, or there is blood loss going on. You see hypovolemic, euvolemic, you see an SIADH. Okay. Is the differentiation clear?
Yes.
Yes.
Okay. Very good. All right. Next question. If a fine needle biopsy of the nodule is consistent with type of thyroid cancer, the patient undergoes total thyroidectomy with central neck dissection. Which of the following is most likely histological finding? Okay. So there is this nodule on the thyroid gland. He was asymptomatic. His medical history significant for recently diagnosed pheochromocytoma. Okay, the patient died with thyroid cancer. Okay, what's happening? What type of cancer is
Yeah, this M1, it
It's the
will be
medullary.
papillary
Yes, medullary
carcinoma.
thyroid.
Medullary
Yes,
carcinoma and
thyroid.
MEN2B. MEN2B. Yeah.
All right. So what will be the answer be?
Maybe C.
A will be the branching structure with
No, BC.
No?
It's
Where
not.
do you see
That is
Congo red
medullary
positive?
carcinoma. I said that.
It's not
Yeah.
papillary.
It's not papillary. It is meant to be because patient also has pheochromocytoma. And this is
Yes,
medullary
yes, yes,
carcinoma.
yes.
Yes.
Whenever you see amyloid deposition, so what is happening in medullary thyroid cancer? There's amyloid deposition, right? Wherever you see amyloid deposition, it's going to stain positive for Congo red. Okay.
Say again that, please. Say again that. Where we see amyloid. Can you repeat?
Sorry, what?
Can you say that again, please?
Yeah, I said whenever you see amyloid deposition, wherever it's going to stain positive for Congo red. Congo red is a dye.
Thank you so much.
All right. Okay. Where else do you see amyloid deposition? What disease?
Amyloidosis, multiple
Amyloidosis.
myeloma,
Alzheimer.
multiple myeloma,
Multiple myeloma.
Alzheimer.
Good.
Alzheimer disease.
Alzheimer's. Very good.
Myeloid angiopathy.
Very good. Good job. All right. Okay. So we have the last question for today. Physical examination shows hair loss involving lateral third of the eyebrows. There is delayed relaxation of the DTRs of the knee and ankle. Which of the following laboratory test is most appropriate next step in evaluation of this patient's symptoms? So, there's this woman who is here for increasing fatigability and 10 lb weight gain. The patient used to swim, but she can't swim now. Blood pressure is 140, pulse is 55. There's constipation going on. What's happening?
Yes,
It's
sign of
hypothyroid.
hypothyroidism. Yes, we
And
can then
serum
check first
TSH we will do.
THS level, more sensitive.
Hypothyroidism?
Yes.
Agree. F.
So it's TSH.
Yes, TSH.
Yes.
Where do you see a dexamethasone suppression test? For what?
Cushing syndrome.
Cushing syndrome.
Syndrome.
What about 24-hour urinary cortisol?
Cushing.
The same one.
Also
What we
Cushing.
should
What do you do first, Dexa or cortisol?
24-hour
Cortisol,
urinary
cortisol first.
cortisol.
Cortisol.
Very good. All right. So again, the patient was having fatigue, weight gain, constipation, everything goes down. Most likely they're referring to hypothyroidism. Any type of, thyroid problem, a patient comes in, you just, check for the thyroid profile first. TSH is very, very sensitive. You don't do triiodothyronine and thyroxine because their levels can fluctuate. The TSH is, very, very specific for any thyroid disease. So thyroid profile, usually a thyroid profile has all, right? It has TSH, triiodot, and thyroxine. It has all of it. But again, as I said, USMLE wants you to be super specific. So they are gonna say TSH aside of, this. Otherwise, thyroid profile is usually the right answer on steps. All right, that is it, guys. We are done for today. I think Dr. Moaz is here. Are you here, Dr. Moaz?
Can I ask you something?
Yeah, sure.
Where we can find Samoma bodies?
Seminoma.
Samoma.
Samoma body.
Samama bodies, yeah. So where else can you find Samama bodies? All right, you can find them in medullary thyroid cancer. Can you find them in medullary thyroid cancer?
Papillary.
Very good. What else?
Meningiomas.
Meningioma.
Meningioma.
Ovarian epithelioma. Cancer body.
That's right. Thank you.
Doctor, can
So
we
it
find it in...
can be in papillary thyroid cancer, meningiomas. It can be cystoadenocarcinomas of the ovaries. They can also be sometimes seen in melanotic schwannomas, but that's a little off for you guys. But in terms of steps, what I want you to remember, the papillary thyroid cancer and meningiomas, they love to test you on that. All right. Basically, they're found in thyroid, ovaries, endometrium, sometimes lining of the central nervous system as well. So yeah. So of course, whenever these areas will have cancer, they will be found in that. So that makes sense, right?
Great. Thank you so much.
All right. Is Dr. Moaz here? Or is there going to be any class? Let me ask. Wait.
I think he'll join after some time.
Hello, everyone. How are all of you?
Fine.
Um, mhm, mhm. Okay, guys. So today we are going to do Graves' disease, thyroid cancer, and diabetes, right? So today we are gonna do Graves' disease, thyroid cancer, and diabetes, right? So any questions regarding these topics or any topics from the past day? Okay. Okay. So is everything clear? Okay. So so let's move. Let's start then. Right. So the first topic that we are gonna do today is the Graves' disease, right? Right. So, what is Graves' disease, right? So, in order to understand Graves' disease, first of all, we have to understand what is hyperthyroidism, right? And a lot of you already know what is hyperthyroidism, but we have to go into the details of hyperthyroidism, especially hyperthyroidism versus hypothyroidism, right? So, the first thing that we're going to cover today is hypo and hyperthyroidism, right? So, what is hypothyroidism? So hypothyroidism means that that your thyroid gland is not working properly, right? So there are the T3 are low, the T4 are low, right? The TSS gonna be high as well, right? And what is hyperthyroidism? So hyperthyroidism basically means that your thyroid gland is producing a lot more thyroid hormones than it should normally produce, right? So what are the signs and symptoms of hyperthyroidism? The first thing that you are gonna get in hyperthyroidism that is very important is the patient is gonna have heat intolerance, right? They're going to give you some signs regarding heat intolerance if the patient is having hyperthyroidism. The patient is going to say, I sweat a lot or I'm getting hot a lot more than what I used to get, right? So the first thing is that the patient is going to get heat intolerance. The patient is going to get increased amount of sweating and the patient is going to get weight loss, right? Why is the patient going to get weight loss? Because we have already stated that whenever thyroid hormones act on the nuclear receptors, so whenever the thyroid hormones go and act on the nuclear receptors, they're going to increase the synthesis of sodium potassium ATPase, right? And sodium potassium ATPase is the main pump of the body, right? This is the main pump of the body that uses the most amount of energy in the body, right? This is going to use a lot of energy, right? So the basal metabolic rate is going to increase, the calorigenesis is going to need increase, and the patient is going to get weight loss, right? And that is the first thing that you're going to have. The patient is going to have heat intolerance, the patient is going to have increased amount of sweating, the patient is going to have weight loss. And the reverse is going to happen in case of hypothyroidism. The patient is going to have cold intolerance. The patient is going to say that I need to adjust the thermostat at a hotter temperature now because I am feeling so cold, right? The patient is going to have decreased amount of sweating, the patient is going to have weight gain as well, right? Now the other thing in hypothyroidism is that the skin is going to be warm, the skin is going to be moist, right? In case of hypothyroidism, the skin is going to be warm, the skin is going to be moist. Why is the skin going to be moist? This is important because there is going to be vasodilation. And why is there why will be there be vasodilation in case of hyperthyroidism? Because in case of hyperthyroidism, I told you that the thyroid hormones act on the beta receptors, right? And if you remember, the beta receptors are present on the blood vessels, right? The beta receptors are present on the blood vessels. So the beta receptors are on the blood vessels, and then the beta receptors on the blood vessels get activated. They are gonna cause vasodilation, and the skin is gonna be moist. The other thing is that there should be fine hair, and is gonna be onycholysis. So what is an onycholysis? Right. So remember, once I was solving a UWorld question, and the only hint that was mentioned of hyperthyroidism in the question was tachycardia. Right. Uh, okay. So the first thing, okay. So when we go to the deep tendon reflexes, I'm going to tell you why are they depressed. But right now we are on the fact that onycholysis, right? So what is onycholysis? So onycholysis means that there are going to be nail changes, right? The nails are going to be broken down, right? The nails are going to be pitted. These are all of the changes that are going to be present in hypothyroidism. And remember, and I was solving once a question on hyperthyroidism, and the only hint that was mentioned in the question was tachycardia, and there was the blood pressure was increased, and the patient was having onycholysis, right? So onycholysis means that the nails are separated from the nail bed, right? Okay, so one thing that is important regarding UWorld and steps and NBMEs are the fact that sometimes they are not just going to give you the words, right? They're not just going to say on equalizes in the question because the steps knows that you are very intelligent, right? You guys are intelligent, they know this, and they are more intelligent than you, right? They are very fast, they are very clever. So what they are gonna do is that they are gonna replace onycholysis with another word, right? They are gonna give you there is distal separation of the nail bed, right? They're gonna say there is distal separation of the nail bed. So remember, you just don't have to cram the symptoms. You just don't have to cram the words. You have to know what do these words mean, right? What do these things mean? What does the separation of the nail plate means, right? What does the separation of the nail plate means? This is known as the onycholysis, right? Onycholysis means that there is going to be separation of the nail plate, right? The nail plate is going to be separated. The nail is going to be separated from the nail plate, right? And it's very well worthy that I show you the onycholysis as well, right? Okay, so right, so this thing is known as the onycholysis. Let me pull up the picture. Yeah, right. So this is the onycholysis, right? So if you see that the nail in the yellowish, in the greenish part, look at the greenish part. The nail is separated from the body, right? The nail is separated from the nail plate. The nail has been risen, right? So this thing is known as the onycholysis, and it's present in hypothyroidism, right? So hypothyroidism has nail changes, and at the same time, there is gonna be ophthalmopathy in Graves' disease, right? There is going to be periorbital edema, there is going to be exophthalmos, right? The eyes are going to be out, there is going to be lid lag, and there is going to be lid retraction, right? So what is lid lag and lid retraction? We are going to go into the detail of it later. But one another important thing that is present in the hyperthyroidism is diarrhea. A lot of people do not focus on it, but hyperthyroidism is a very important cause of diarrhea, right? Hyperthyroidism is a very, very important cause of diarrhea. In your mind whenever you are having diarrhea, right? Now, both of these conditions are gonna have libido decrease, infertility, uterine bleeding, gynecomastia. Both of these things are gonna be present in both of these conditions, right? Now, hypothyroidism, there is gonna be right. So in case of hypothyroidism, and there is gonna be bradycardia, right, and there is gonna be dyspnea on the exertion. Whereas in the case of hyperthyroidism, there is gonna be tachycardia, there is gonna be palpitations, there is gonna be dyspnea, and there is gonna be arrhythmias, right? So one important thing is that if a patient is having atrial fibrillation, so one week atrial fibrillation. So whenever a patient has atrial fibrillation and there is no other known cause of atrial fibrillation, that the patient is completely normal. The first thing that you are going to do in this person is you are going to do an TSH level, right? Why? Because hyperthyroidism is a very important cause of atrial fibrillation, right? Hyperthyroidism is a very important cause of atrial fibrillation, right? So these are all the signs and symptoms. The only thing that is left behind are the musculoskeletal changes, right? The only thing that is left behind are the musculoskeletal changes, right? And if you look at the musculoskeletal changes in both of these conditions, there is gonna be muscle wasting, right? There is gonna be muscle wasting in both of these conditions. Now, how do we differentiate between the muscle wasting of hypothyroidism and hyperthyroidism? Like, how do we differentiate between the muscle wastings of hypothyroidism and hyperthyroidism? Right. So, in case of hypothyroidism, whenever there is gonna be muscle wasting, you are gonna get weak muscles. The CK levels are gonna be raised. Right. There are gonna be increased CK levels. Whereas in case of hyperthyroidism, there is the CK levels are gonna be normal. Right. The CK levels are gonna be normal. Right. Now, in case of hyperthyroidism, there are going to be increased tendon reflexes. The deep tendon reflexes are going to be hyperactive. Whereas in case of hypothyroidism, it's going to be decreased, right? In case of hypothyroidism, it's going to be decreased. Okay. Now, okay. AFM and hyper AFM wasn't mentioned. That is too difficult question. Okay. Why deep tendon reflexes are decreased in hypothyroid? Right. So now let's jump on to the fact that how deep tendon reflexes are decreased in the hypothyroidism. Right. So remember one more thing. In hypothyroidism, we have a thing which is known as labial myxedema. Right. So in case of hypothyroidism, there is myodema. Right. There are gonna be edema everywhere in the body. hypothyroid patient presents with edema, right? And why do these patients present with edema, right? We have a thing which is known as the GAGs, right? So the GAGs stand for the glycosaminoglycans, right? So what is going to happen is that these glycosaminoglycans are going to go into the interstitial space. So what is the interstitial space? Is if this is the blood vessels, right? Right. So if this is the blood vessel, this is the cell, right? If this is the blood vessel, this is the cell. Here if there is the blood, right? This space is known as the interstitial space, right? So what is going to happen is that in case of hypothyroidism, the glycosaminoglycans are gonna get accumulated here, right? And when the glycosaminoglycans are gonna go here, the water is gonna accumulate here as well, right? And now there will be a lots of edema that will be present here, right? So the overall picture of a hypothyroid patient is going to be very myxomatous, or there is going to be very severe myxedema. There is going to be very myoedematous status of this patient. Now, why is this thing important? This thing is important because if this is the muscle, right? If this is the muscle and this is the nerve, right? So if this is the nerve, this is the muscle, right? We need a time response between this nerve and this muscle, right? And this thing is known as the conduction, right? So there is going to be a conduction velocity, right? And the faster is the conduction velocity, the faster is going to be the reflexes, right? So if the conduction velocity is faster, the deep tendon reflexes are going to be fast. But what happens in hypothyroidism is that all of this space is now going to be covered with glycosaminoglycans and waters, right? So there is going to be increased amount of water and glycosaminoglycans here, which act as an insulator, right? So just imagine, like just like fats act and in fact acts as an insulator, plastic acts as an insulator, glycosaminoglycans are going to act like an insulator, and they are not going to let this nerve impulse to travel to the muscle. This nerve impulse is not going to travel to the muscle. When this nerve impulse is not going to travel to the muscle, the deep tendon reflexes are going to be depressed, right? They are going to be decreased deep tendon reflexes, right? Okay. So I would like to explain more on the hyperthyroid versus hypothyroid, but we are very limited on time today, right? Because we have a lot of topics that we have to cover today, right? Right. So, any questions? Any questions regarding hypo versus hypothyroidism? If yes, tell me. I have
Doctor,
3 minutes to answer. Yes.
then why does the dependent reflexes increases in hypothyroidism since the edema is also present in hypothyroidism?
Okay. So in case of hyperthyroidism, there won't be any edema, right? In case of hyperthyroidism, the edema is only present in two places, right? There is no edema in case of hyperthyroidism, right? In case of hyperthyroidism, edema is only going to only be present in case of Graves' disease, right? It will only be present in case of Graves' disease, and that will only be present in the eye, right? And why is that? Why is Graves' disease gonna have edema in the eye? Right? So let's first focus on that, right? So if we go to the Graves' disease, what is Graves' disease? Graves' disease is the most common cause of hyperthyroidism, right? And what happens in Graves' disease is that we are gonna have an antibody which is known as the IgG, right? So we are gonna have thyroid stimulating immunoglobulin, right? Now, what is this thing gonna do? So if we have this thyroid here, right? If we have this thyroid here, there are going to be TSH receptors on these thyroids, right? And when TSH binds on these receptors, the thyroid is going to make more T3 and T4. In Graves' disease, instead of TSH, IgG antibodies are going to bind here, right? So the body is going to form antibodies, and these antibodies are going to bind here. And when these antibodies are going to bind here, a lot of thyroid hormone is going to be produced, right? A lot of thyroid hormone are going to be produced, right? Is it clear?
Can you please repeat
Yes.
the sentence again? This instead of TSH, the IgG bodies bind with the thyroid.
Okay, so guys, see, whenever the body wants more thyroid, what does the body do? The body goes to the thyroid gland. The body asks the pituitary gland to secrete TSH, right? And the pituitary secretes the TSH, and then this TSH goes to the thyroid And this TSH asks the thyroid to produce more and more thyroid hormone, and as a result we get more and more thyroid in the body, right? We are going to get more and more thyroid in the body. Now whenever we are getting more and more thyroid, this thyroid is going to go back to the pituitary and it's going to say, I don't want any more pituitary, I don't want any more TSH from you. And then the TSH secretion is going to stop, and there is not going to be there won't be any hyperthyroidism, right? But what happens in case of Graves disease is that these patients are going to make IgG antibodies, and these IgG antibodies are going to bind here on the TSH, right? These IgG antibodies are going to bind here on the TSH, right? Right? These antibodies are going to bind here on the TSH, right? And when these antibodies are going to bind here, more amount of thyroid hormone is going to be produced, right? The thyroid hormone is going to be produced here, and the thyroid hormone is going to be increased a lot, right? This is what is going to happen in case of Graves disease. Did you understand it?
Yes,
Okay. Now, the question that was asked, that why there is edema in case of Graves disease as well, right? In case of hyperthyroidism, generally there is no edema. No edema is present in case of hyperthyroidism, but only in two places there is gonna be edema. The first place are the legs, and the second place are the eyes. Why? Because in both of these places we have fibroblasts, right? We have the dermal fibroblasts in the legs, and in the eyes we have the orbital fibroblasts, right? Now what is going to happen is that both of these things are going to get stimulated by these antibodies, right? These antibodies are going to come here, these antibodies are going to stimulate these things, right? And then whenever these antibodies are going to come here, T cells or the immune system is going to come here. It's going to attack these antibodies. Whenever these antibodies are going to get attacked, cytokines are going to secrete. So cytokines are going to increase, and the cytokines are gonna produce the formation of gags, right? And then there is gonna be water accumulation, then there is gonna be swelling, right? And but this thing is only gonna happen in the eye and the legs. That is why the eye are gonna come forward, there is gonna be exophthalmos, right? And the legs are gonna be thick as well, right? So there is gonna be pretibial mixed edema as well. But again, this thing is happening only in two places. This thing is happening in the legs, and this thing is happening in the eye, right? Only two places where this thing is gonna occur, right? Eye and legs, no, not elsewhere, right? But this mechanism is very different from the mechanism of hypothyroidism, right? So in hyperthyroidism, please remember this concept, right? These things is known as the Graves of ophthalmopathy. It's gonna damage the ocular muscles, right? So there is gonna be exophthalmos, the eyes are not gonna move, and you're gonna get very worse symptoms, right? Okay. So edema accumulation in the thermos. Okay, sure. Okay, so what happens? Okay, okay. So okay, so if this is the eye and this is a layer of the eye, right? Now here there are gonna be fibroblasts, right? So what are fibroblasts? Fibroblasts are cells that secrete the fibers and they cause the growth of the body, right? They basically cause the growth of the body by secreting fibers and all of the stuffs, right? Now, what is going to happen is that in case of Graves disease, these fibroblasts are going to get activated by the IgGs, right? The IgGs are going to come. The IgGs are going to come. They are going to activate these fibroblasts. At the same time, whenever antibodies come at a place, right, the T cells are going to come there as well. The T cells are going to come here. They're going to attack these fibroblasts, right? When these fibroblasts are going to get attacked, increased amount of cytokines are released and the fibroblasts are going to get activated. And then those fibroblasts are going to secrete a jelly-like material which are known as the GAGs, glycosaminoglycans. The glycosaminoglycans are going to fill here, right? They're going to fill here completely, right? And they're going to bring a lot of water with them. They're going to bring a lot of water with them as well. A lot of water with them is going to be brought here, right? And this thing is going to get small, right? And then the eye is going to be popped forward, right? Here there are going to be muscles, right? So the muscles are gonna be here, the muscles are gonna be here, the muscles are gonna be here, the muscles are gonna be here as well. These muscles are gonna get swollen, those muscles are gonna get inflamed, right? And then these muscles are not gonna work anymore and the eyes are gonna get weak. This thing is known as the Graves of ophthalmopathy, and this is the exophthalmos that happens in case of Graves disease, right? Now remember, Graves disease is associated with two HLA mutations. You have to cram these. These are the HLA-DR3 and these are the HLA-DR B8. These are the HLA-DR3 and the HLA-B8, right? Okay. GAGs are hydrophilic. Yes, GAGs are hydrophilic. They are gonna accumulate water. Yes, they are gonna absorb water. The water is gonna come towards the GAGs, right? You're very welcome, right? Any other questions regarding this? If not, we are gonna move forward.
What's the major cause of diarrhea in hypothyroidism?
Okay. So what was the cause? Okay, so first of all, remember one more thing that I forgot to tell you, that in case of hypothyroidism, okay. So remember two things, right? So this was something that my surgery professor once told me, and I really loved this fact, and it has helped me a lot in my life, right? So hyperthyroidism is the easiest disease in the world to diagnose, right? And it's the most difficult one to treat, right? Hyperthyroidism is the easiest one to treat and the most difficult one to the easiest one to diagnose and the most difficult one to treat. And hypothyroid is the most difficult disease to diagnose, and it's the most easiest one to treat, right? Because whenever a patient is having hypothyroidism, you're gonna just give the patient levothyroxine. That's it. The patient is gonna improve. But in case of hyperthyroidism, you have to titrate the medications again and again and again, right? You have to do a lot of TSH, right? You have to do a lot of thyroid stimulating hormone tests. You have to do a lot of T3 and T4 tests, and still then the patient is not going to be completely normal, right? It's very hard to bring down the thyroid hormones to a normal level. So in the end, there is only one thing that you can do. You just cut out the thyroid from the body, right? You just cut out the thyroid. Right? So from this comes the fact that in case of hypothyroidism, one important thing is that the patient is going to have constipation, right? And sometimes the U words are going to only mention two, or the U word, the NBMAs, the USMLEs are only going to mention two effects, right? They are only going to mention two effects. And one is hypothyroidism, the constipation in hypothyroidism. The second one is increased amount of cold intolerance, and the third one is bradycardia. So they are going to give you a patient who is having increased amount of sensitivity to cold, and he is constipated, and he is having low pulse rate as well. And the diagnosis of hypothyroidism is very subtle, right? That is the first thing. Now the second thing is that why do we have diarrhea and hyperthyroidism? That is very simple, right? I told you that the thyroid hormones act on the sympathetic system, right? The thyroid hormones are going to act on the sympathetic system, and whenever the sympathetic system okay, so that is okay. So first of all, that is the first thing. Now the second thing is that whenever a patient is hyperthyroid, the patient is going to have increased amount of metabolism, right? The metabolism and the oxygen demand is going to be increased, right? And whenever the oxygen and metabolism is increased, the blood flow in the intestine is going to be increased, right? The blood flow in the intestine is going to be increased, and that is going to enhance the motility of the gut, and increased amount of fluid secretion is going to occur, right? And as a result of that, you're going to have diarrhea, right? You're going to have diarrhea, and so this is how it's going to happen, right? Now, any more questions regarding hypothyroidism? If not, let's move forward. Okay. Anything about Graves' disease in particular? Okay, so please remember the pathophysiology. There are gonna be antibodies. Those antibodies are gonna act against this thyroid hormone, right? TSH receptor. The thyroid function is gonna increase. There is gonna be hyperthyroidism, and at the same time, there is gonna be infiltration on the orbital space. Orbital fibroblasts are going to be activated. They are going to release cytokines. There is going to be local inflammatory response. Fibroblasts are going to proliferate. Glycosaminoglycans are going to come. When the glycosaminoglycans are going to come, the fat and the muscle tissue and the water is going to increase there, right? Okay. Now, what are the diagnostics? So I think so. I believe these are so important that I should have another lecture on them, right? I personally believe I should have a lecture on them for separately, right? But right now we are just going to do these things, right? So, what are the diagnostic tests of hypothyroidism, right? Sure, I'm going to tell you the questions on HLA-DR3 and HLA-V8, but first, dyspnea and hypo. Okay. So, but let's first focus on this thing, right? Can we do the Q&A in the end? Okay. So, let's focus on one other thing. That is, what are the laboratory analysis in case of hyperthyroidism, right? Especially Graves' disease. Right? So, whenever you look at the Graves' disease, you are seeing that the patient is going to have increased amount of T3 and T4, right? Because the thyroid hormones are going to be increased, so you're going to have increased amount of T3 and T4. And can anyone tell me when the T3 and T4 are going to be increased, what is going to happen to the TSH?
Decrease.
Decrease.
Yes, so the TSH is going to be decreased, right? And the final test that we can do is we can do TRAP test, right? So TRAP test stands for thyroid receptor autoantibodies, right? So this is a TSH receptor antibodies. So TSH receptors antibodies, we can do this test, and this test is going to come positive as well. And this is going to confirm our diagnosis of hyperthyroidism, right? Now, HLA-DR3 and B8, let's go towards it in the end, right? But let's first do all the cancers of thyroid, right? Because today we have to cover the cancers, we have to cover some other things as well. Okay. Hmm. So we have to do the cancers, we have to do diabetes as well today. Okay, so let's move on to the thyroid cancers. The first thing that you should know regarding the thyroid cancers is the fact that what are the risk factors of thyroid cancer? What are the patients in which you can expect a thyroid cancer to be present, right? Right. So the first patient that you can expect a cancer is those patients who have a history of radiation in adult in childhood, right? So whenever a person comes to you and that person says that I had a history of radiation in childhood, right? Then the first thing that should come to your mind is a thyroid cancer, right? That is the first thing that should come into your mind, right? So whenever a patient comes to you and that patient had a history of radiation, right? Then the patient that should come into your mind is a patient who's having a thyroid cancer, right? Now, what if I tell you that a patient is so, for example, let me make up a question for you, right? So, for example, what if I say you that a patient comes to you and that patient belonged to a village of Russia, right? So that person belonged to a village of Russia, right? And sometimes they ask about some common knowledge question as well and general knowledge questions as well. So they were gonna say that the person belonged to a village of Russia, right? And there is a disease that is very prevalent there, right? So what disease is gonna be prevalent there, right? Sometimes they're just gonna ask you this question. So this is how they combine biostats with a system, right? This is a clever way of combining biostats with the system, because you have to understand the biostats, right? You have to understand the epidemiology. So the first thing that should come into your mind from the village of Russia is going to be Chernobyl, right? So Chernobyl had radiation exposure, right? Or they can give you a city of of Japan, right? So they can give you Hiroshima, they can give you Nagasaki as well. And at that place there were nuclear radiations as well, right? And again, whenever a patient is having a history of radiation, the first cancer that comes to your mind is thyroid cancer, right? So this patient is going to have an increased amount of thyroid risk of thyroid cancer, right? So okay. So look at the patient history, look at what is happening in the patient. So yes, so thyroid cancer is also present in radiologists as well, right? So because radiologists are exposed to a lot of radiation. Now, this is the first thing that is important regarding thyroid cancer. The second thing is that how are you going to diagnose that thyroid cancer? So in order to diagnose the thyroid cancer, you have to do an FNAC, right? So the FNAC means the fine needle aspiration cytology, right? How do you treat it? In order to treat it, you just remove the thyroid. Just remove the thyroid and the patient is going to get better. Okay. Now, there are some complications of the surgery, right? The first complication is that I told you already that the patient sometimes the if this is the thyroid, there are parathyroids that are present here. The parathyroid can get removed and you can have hypocalcemia, right? Now, what are the signs and symptoms of hypocalcemia? We are going to cover it in the parathyroid system, right? We are not going to cover those today, right? But remember, whenever a patient is going to have thyroid cancer, the patient is going to come to you with hypocalcemia, right? There is going to be chorionic sign as well as there is going to be trousers sign. Okay. No, forget it. Let's do hypocalcemia here today as well, right? Let's do hypocalcemia here as well, right? So what is hypocalcemia? So hypocalcemia means you are having less amount of calcium, right? And whenever you are having less amount of calcium, you are gonna have tetany in the body, right? You are gonna have tetany in the body, right? The patient is gonna have increased muscle stiffness, right? The patient is going to have increased muscle stiffness. The patient is going to have muscle spasms, right? The patient is going to have muscle spasms. At the same time, the patient is going to have tingling, right? The patient is going to have tingling or pins and needle sensations. That is the second thing the patient is going to have, right? These are the two most important things that the patient is going to have, right? The third thing is that the patient could have carpopedal spasm as well, right? Okay, guys. So one random memory tip that I can give you guys is that can help you a lot is always try to remember things by images, right? Always try to remember things by images, right? There are a lot of diseases. There are a lot of symptoms. So the way I try to remember these diseases or the symptoms were, and believe me that I was talking to Dr. Ahmed and Dr. Hamza about it as well, right? So uh, I'm gonna tell the other risk factors as well, thyroid cancer, right? So I saw like 1 week ago there was a new AI model that was the Google View, right? So that was the Google View or that was the Google Flow, right? So that was View 3, and it you can just enter a prompt and that system is gonna make some good videos for you, right? That is gonna make AI generated video for you guys. So the best way you can remember thing is by creating an image or a video of a picture of a patient who is coming to you with a particular diagnosis, right? So whenever I think of hypocalcemia, I think of a person, right? So first of all, I'm looking at what kind of a person is going to have hypocalcemia, right? So that is the first thing. So I am thinking of a person who just had an accident, right? Because after accident, hypocalcemia is common, right? Or that person had uh, a surgery of thyroid, and after surgery of thyroid, so I'm thinking of a person that is lying in a ward, and in the ward, in the medicine floor, that patient is having thyroid that was removed, right? Or that patient had a surgery, right? Or I'm thinking of a chilled child, and that child is having problems of the ear or the face, and cardiovascular defects as well, and that patient is now presenting with carpopedal spasm, and now this patient is having tingling perioral muscle spasms as well, right? So this is what I'm gonna have. Uh, I am gonna think of, right? So I'm gonna think of a boy, a very small boy, right? I'm gonna think of a person who was exposed to radiations early in their age, and now he had a surgery. Or I'm gonna think of a person who was driving very fast and he had a surgery, and then he had all of those things, and then there is going to be two tests, right? So these patients are going to have two tests. The first test is the Chavostic sign, and the second one is the Trausius sign, right? So what is Chavostic sign? So Chavostic signs means that whenever you tap the cheeks, right? So just think you're tapping the cheeks. So whenever you tap the cheeks, you're gonna get contractions of the facial muscles, right? So just think of it as a baby. So whenever you touch the baby, you touch the baby's cheeks, you're gonna contraction. The second thing is that you can have Trausios sign as well, right? So what is Trausios sign? So Trausios sign is that you're gonna have contraction of the arms, of the hands, uh, whenever you inflate a blood pressure cuff, right? So they could give you a question that a patient had a thyroid cancer and the patient came for a surgery and surgery was done successfully. But now whenever you are trying to take the patient's blood pressure, the patient's arm and the patient's hands are contracted. And that is the only hint that they are going to give you, right? And then you are going to think, what in the hell is this patient having, right? What is this patient having, right? What's wrong with this patient, right? So one other tip that I can give you guys is that try to solve the questions with as minimum amount of information or knowledge as you can, right? It's very easy to solve the question if you just know all 10 of the symptoms and signs, right? Try to get only one sign, right? Try to just look at one sign and see, okay, what is the diagnosis? Okay, if you cannot get it with one sign, one symptom, move on to two, move on to the third one, then move on to the fourth one, and then go on and so forward, right? So this is how you're gonna go. Because sometimes the question are gonna just mention one main thing or one main tip. But Rousseau sign and Chvostik sign are very important, and hypocalcemia is extremely important, right? So now how are you going to treat hypocalcemia? You are going to give the patient IV calcium. So all the main thing that I was saying was that whenever a patient is going to have thyroid cancer, the patient can have hypocalcemia, right? And the hypocalcemia is going to present like this, right? And now, what are the other risk factors of thyroid cancer? One was radiation, right? So radiation was a very important risk factor, right? Now, the the main one is so the main the one that you need to remember is the ionizing radiation, right? After that, there are some main syndromes that we are gonna cover at in the pathology portion, right? But that is one. The second thing is that one important thing is that there are two arteries of the thyroid, right? Regarding surgery and anatomy, there are two arteries of the thyroid. One is the inferior thyroid artery, right? Another is the superior inferior thyroid artery, right? And the other is the superior thyroid artery. Why are these arteries important? I think you may know because this was the question that was asked, was the most in the head and neck portion of the anatomy, right? So inferior thyroid artery is very near the recurrent laryngeal nerve, right? So it's very near the recurrent laryngeal nerve. And you guys already know that whenever a recurrent laryngeal nerve is damaged, you are going to have hoarseness of the voice, right? You're going to have hoarseness of the voice. So it was my fifth year ward test, and I came to a patient, right? And I was taking the history of the patient, right? And the patient had thyroid cancer and the patient had papillary thyroid cancer. But I could not take the history from the patient because the patient had done the surgery, had her surgery done from a quack, and that quack had damaged the patient's inferior thyroid artery along with the recurrent laryngeal nerve. And the patient had so much hoarseness of voice, and that the patient had dysphonia. The patient could not speak, right? The patient could not speak, right? The patient could not speak. Now, the superior thyroid artery can get damaged as well, right? But its damage is not superior that important because it's gonna lead to the damage of superior laryngeal nerve, right? And only a minor loss of tenor is gonna be observed, and this is gonna be important for the patients who are having professional voices, right? So the patient who are singers, the patient who are dancers, right? The patients who are narrators, the patient who are actors, right? Those need the superior laryngeal nerve because that is going to control the fine movements of the tongue and the fine movements of the vocal cords to get a deep voice or a specific voice that you want, right? So these are all the complications regarding thyroid cancer, right? Now, the first time, what is the most common thyroid cancer? Most common thyroid cancer is the papillary cancer of the thyroid or the papillary carcinoma of the thyroid gland, right? That is the most common cancer of the thyroid. The second most common thing regarding this cancer separates by the lymph nodes, right? So if they give you a thyroid cancer, if the cancer has some kind of a thyroid and the lymph nodes are palpable, the first thing that should come into your mind is papillary thyroid cancer. And remember, this is a very important fact regarding the papillary thyroid cancer, right? Uh, Now you're gonna say that Dr. Moaz has seen a lot of different patients in the wards, right? So in my surgical rotation, I saw a patient, and that patient just had only palpable lymph nodes, right? That patient only had palpable lymph nodes, and the thyroid was completely normal, right? Thyroid is completely normal. The patient came to us, and the patient had a palpable lymph nodes. We palpated the patient's lymph node. We'd send the patient for a biopsy, right? And the biopsy was positive for a papillary cancer of a thyroid. So this is the cancer that you are going to detect with the help of lymph nodes. So keep this in mind. This cancer is very much present in the lymph nodes, right? So this is important. Now, the second thing is that, so this is done. The second thing is that this cancer had very good prognosis. The prognosis of this cancer is very good. It has great prognosis. Now, in papillary carcinoma, you're gonna get some HOMA bodies, right? So the histology is gonna show you some HOMA bodies. Now, you world and NDMs and UMSMLEs already know that every single person who is taking the exam, they know what are some HOMA bodies that they're going to be can present in the case of papillary thyroid cancer. So they are going to replace the word some HOMA bodies with some other word. They are going to give you well laminated calcifications, right? They're going to give you well laminated calcifications, right? Or they are going to give you some other thing, right? Patients, right? It is most prevalent. So P stands for papillary cancer. P stands for P stands for papillary cancer. P stands for prevalent. So it's the most prevalent. P stands for palpable lymph nodes. P stands for papilloma. Samoma bodies. P stands for prognosis, which is very good. Right now, it's common with childhood irradiation and red mutations. We are going to go into the detail of red mutations later, right? Now, one important thing that is present in case of papillary cancer of the thyroid is orphan and I nuclei, right? So we are going to have orphan and I nuclei. So what is orphan and I? So first of all, orphan and I was a character that was present in the American comic strips, right? It was present in 1800, 1900s, right? So this was a so if you look here, I hope all of you can see this female, right? Look at the patient's eye, right? Look at the person's eye. Look at the cartoon's eye. The eyes are completely white. Can all of you appreciate that?
Yes.
Yeah.
Okay.
Yeah.
Now, let's go to the papillary cancer of the thyroid. Mhm. Okay, so now look here. Can you appreciate? Can you see the common histology here? Why is it called as the orphan and eye nuclear?
Yes.
Yes, so it's
Yes.
white. Right?
Yes.
So all of the cells are completely white. So this is why we call it as the orphan and eye nuclear, right? So this is the one thing that is present in the papillary cancer. The other thing are the samoma bodies, right? So let me tell you about the samoma bodies as well. So see, these are the world calcifications, right? So they are not going to give you samoma bodies anymore. They are going to give you world calcification, round calcification, smooth rounded calcification, smooth oval calcifications, any of those things. Or they're going to just give you this picture and then they're going to ask you what cancer did this patient have. And you cannot expect to say that the histology was hard, right? These are the samoma bodies. Can all of you appreciate that? Any problem in this?
No.
Okay. Any questions regarding it? Okay.
No.
Now the next cancer is the follicular cancer or carcinoma of the thyroid, right? Again, the follicular carcinoma of the thyroid, so is having a very good prognosis, right? So the prognosis is good, right? Now, the important thing regarding that is follicular cancer separates with the help of blood, right? The follicular cancer is not going to separate with lymph nodes, it's going to separate with the blood, right? We have another thing which is known as the follicular adenoma, right? So what is the difference between these two, right? So if the cancer is benign and it does not invade, so if this is the thyroid, right, and these are the follicles, right? If this is the thyroid, these are the follicles, right? And this is the capsule of the thyroid, right? As long as this cancerous cell does not invade the capsule, we are going to call it the follicular adenoma. It means that the follicles are going to grow, right? The follicles are gonna grow, right? And they are gonna cause a benign. This is gonna be a benign growth, right? So this is gonna be follicular adenoma, and there is gonna be absence of capsular invasion, right? So if there is no capsular invasion and the follicles are growing, we call it as a follicular adenoma. But what if the same follicles are now invading the follicular capsule? This is known as the follicular carcinoma. And follicular carcinoma separates with the help of uh, blood. It does not separate with the help of lymph nodes. It uses blood separate. So to separate. Now, one important thing that I want to tell you is that what is FNAC? Right. So FNAC means that we stick a needle in here and we take fluid out of it. Right. We stick a needle inside here and we take the fluid out of it and we check the fluid that what kind of cells are present in the fluid, right? So if orphan and eye cells are present, we are sure that this patient is having papillary carcinoma. But if follicular cells are present and there are increased growth of the follicular cells, then we can think the patient is having follicular adenoma. But can the FNAC tell us about whether the patient is having follicular adenoma or not, follicular cancer or not, or
No.
differentiate between? No. So it's not
No.
going to tell us that, right? It's
Because
not
it
going
can
to.
mask the whole nodule. That's why.
Yes, so it's not going to tell us. It's not going to tell the difference between that. Keep this thing in your mind, right? It's not going to tell us the difference between that. This is very important, right? So in order, Now, the third thing is medullary cancer, right? So, what is medullary cancer? So, if you look at the thyroid is going to have two cells. The first are the follicular cells, the second are the parafollicular cells. And the parafollicular cells produce calcitonin, right? The parafollicular cells produce calcitonin. And these are used for the calcium, right? So, these are going to produce calcitonin, right? Now, the parafollicular cells are going to make calcitonin, right? And what is going to happen is that in this kind of cancer, this is again associated with men 2A and men 2B. So I think we're going to study this cancer in detail in the men 2A and men 2B section. Yes, Dr. Sana. Yes, in
Dr.
aspirate in
Moss,
FN. Yes.
yes, that's my question. In FNAC, we aspirate cells and fluid both together.
Yes, so in FNAC we just aspirate the fluid, and in that fluid some cells are going to be present as well, right?
Okay.
Try to
Thank you.
aspirate the fluid. Okay. Okay, so now the second thing is that in follicular carcinoma, the histology is going to show a amyloid stroma, right? So there is going to be amyloidosis, right? And whenever amyloidosis is present, you are going to see this with a Congo red. So there is going to be Congo red stain that is going to be present with amyloidosis, right? So in order to summarize, and the last one is undifferentiated or the anaplastic carcinoma. The undifferentiated carcinoma is very easy. These patients are and the patient with undifferentiated carcinoma or anaplastic carcinoma are going to have a neck mass, and that neck mass is going to enlarge very rapidly, and that neck mass is going to present to compress the trachea, it's going to compress the esophagus, the patient is going to have dysphagia, dyspnea, and hoarseness, and it's the prognosis is very poor, right? The prognosis is very poor, right? So now in order to summarize all of these, so now let's summarize thyroid cancers, right? So if they give you a thyroid cancer and they say that the lymph nodes are palpable, the thing that should come into your mind is papillary cancer. If they give you a,
Papillary.
yes, if they give you a thyroid cancer and they say that the thyroid cancer has a good prognosis, papillary cancer. If they give you a thyroid cancer and they say it's Congo red and it is having amyloid stroma, the thing that should come into your mind is medullary cancer, right?
Medullary.
If they give you a cancer and they say that this cancer is producing calcitonin, the thing that should come into your mind is medullary cancer. If they give you a cancer and they ask you this thyroid cancer suppressed with the help of blood, the thing that should come into your mind is follicular cancer. If they give you a cancer and they say you cannot differentiate between this cancer with the help of you cannot differentiate these cancer with the help of a fine needle aspiration pathology, the thing that should come into your mind is a
Follicular.
follicular cancer, right? If they give you a cancer and they say that the patient was completely normal 2 weeks ago, 2 months ago, and now this patient cannot eat anything, then the patient cannot breathe easily. What cancer would come into your mind? It's going to be undifferentiated or anaplastic carcinoma, right? If they give you a cancer and they say after the cancer the patient is having hoarseness of the white, what should come into your mind? The thing that should come into your mind is that inferior thyroid artery has been damaged, the recurrent laryngeal nerve has been damaged, right? If they give you a patient and that now this patient is having carpopedal spasm, the thing that should come into your mind is this patient has a removal of all of the parathyroid glands and the patient is having hypocalcemia. Right? Okay, is everything clear?
Yes, Dr. Moss.
Yes.
Yes.
Okay. Now, okay, so now we are gonna start. So now we are gonna start diabetes. Right?
Sir, are we gonna do the subtypes of hypothyroidism, or we should do it ourselves?
No, no, we'll do it, right? So we are going to. So let me look at the schedules. Right? Second. Wait. We are going to cover all the pathology and we are not going to leave anything behind, right? Yep, I think we can do it tomorrow. Okay. So now we are going to do diabetes, right? The most prevalent disease in Pakistan and the South Asia, right? So it's the most common disease. So how is diabetes gonna present? The patient is gonna present with polydipsia, polyuria, and polyphagia. These are the three P's of diabetes. The patient is gonna say, I'm having increased urine, I'm gonna have increased water thirst, I'm gonna have increased amount of I wanna increase the amount of appetite, right? And the patient is gonna have weight loss as well. Now there are two complications of diabetes, right? We are gonna go into the detail of them in some time, right? The second thing is that in case of diabetes can also be caused by two things. The first thing is that GH increased. We have already gone into the detail of how GH increase causes diabetes. It's gonna cause insulin resistance, or to patients who are using cortisol or who are using glucocorticoids. These can have diabetes as well. And the third thing I told you that epinephrine, especially those patients who are having pheochromocytoma, they can have diabetes as well, right? Now, what are the complications of diabetes? In order to look at the complications of diabetes, first of all, it's going to damage the small vessels, right? And we have already discussed how diabetes damages the small vessel, right? So, do all of you remember the hyaline arteriosclerosis?
Yes.
Yes. So, it's
Yes.
going to do hyaline arteriosclerosis at three places: the eye, the kidney, the nerves, right? These are the three main complications, microvascular complications. So it's going to damage three small vessels at three places, right? The eyes, the patients are going to have diabetic retinopathy. The kidneys, the patients are going to have diabetic nephropathy, right? And the third is the nerves, right? So these three places are going to be damaged with the help of the diabetes. So the patients are going to have diabetic neuropathy as well, right? The important thing that is present here is that these three complications and can be controlled by lowering the blood glucose level. By lowering the blood glucose level, HbA1c levels, and keep it in below 7%, we can control it, right? But if the HbA1c 7, but so these three can be controlled. The patient can control the retinopathy, neuropathy, and the nephropathy, right? Now there are some large vessels as well, right? So what are the large vessels? The large vessels are the brain. So in these are the brains, the gut, the heart, and the peripheral arteries, PADs. So the brain is gonna get stroke, the gut is gonna get mesenteric ischemia, the heart is gonna get myocardial infarction, the legs are gonna get peripheral arterial disease as well, right? So these are the things that it is gonna do. Now, MI is the most common cause of death in diabetics, right? MI is the most common cause of death. Now, the recent studies have indicated as that if you control the diabetes even below 7%, right? So if the HbA1c is 7% or below that, that is not going to control these large symptoms diseases. And the large vessel diseases are due to atherosclerosis. And these are not going to be controlled with the help of good diabetic control, right? Unfortunately, right? So if you have any patient, right? So if you are having any patient, just keep this thing in mind, right? If you control the patient's diabetes, those patients are going to still have increased chances of heart attack, stroke, and all of those things, right? This is a sad reality of diabetes. Now, how do we control these symptoms? In order to control these three things, we can give the patient statins, right? The first thing is that we can give the patient statins. The second thing is that we can give the patient SGLT2 inhibitors, right? So empagliflozin and dapagliflozin. We are going to go into the details of this in the my physio pharma portion, right? And the third one is GLP-1 analog, so Ozempic. Right? These three are going to reduce the mortality of the large vessel disease. Remember, if they ask you what is going to reduce the mortality of small vessel disease, then it's going to be diabetic control. What is going to what is going to reduce the risk of large vessel disease? Then it's going to be statins, SGLT2, and GLP-1 analogs. Right? Any questions till now?
No.
Can we do diabetes tomorrow and finish thyroid disorders today? Let's finish that. Okay, so I'll look. So if we can finish the thyroid disorders today as well. I'm gonna try that we at least finish the
Doctor,
hyperthyroid disorders.
Doctor,
Okay.
what did you say for the small vessel
So for
treatment?
the small vessels, there are three areas these can get damaged, and these are gonna get damaged due to hyaline arteriosclerosis, right? So remember, they are gonna ask you a patient is having heart attack, diabetes. What is the pathophysiology of this thing? And that is atherosclerosis. And then they could give you anything from atherosclerosis. The foam cells, the LDL, all of those accumulation, and then they could ask you any single thing, the platelet derived growth factor or any of those things, right? And then you should know that. But if they ask you small vessel disease, then you should know that this is due to hyaline arteriosclerosis. Okay? And there is going to be hyaline vessels, there is going to be amyloid material, the histology is going to see eosinophilic material that is going to be present, right? So This is how you should remember these things. Now, the criteria of diabetes is very easy, right? There is nothing. Just remember this criteria, right? So this is the criteria. The HbA1c, if it's greater than 6.5, if the fasting plasma glucose is greater than 126, right? If the 2-hour OGTT is greater than 200, if the random plasma glucose is greater than 200, right? So this is the criteria. Now we're gonna go the difference between type 1 and type 2 diabetes mellitus, right? What is the difference between type 1 and type 2 diabetes? Let's go into the detail of that. So what causes type 1 diabetes mellitus? So type 1 diabetes mellitus is usually present due to the fact that, okay, so let me tell you a very important factor, right? Let me tell you important historical fact, right? So do you know which country in the world has the highest prevalence of diabetes?
Pakistan.
Yes,
US.
so it's Pakistan.
United
So it's
States.
Pakistan. It's Pakistan. So it's Pakistan, and then there is India as well, and there is Bangladesh as well. So all of these areas have the highest prevalence of diabetes. And does anyone know why is the fact that these areas have the highest prevalence? We still eat healthy food as compared to the US and other countries. Why do we have the highest prevalence of diabetes? Even
Because we
though,
are getting diabetes, we
Genetic.
are living longer.
so why do we have genetic predisposition towards diabetes?
HLA.
Hmm? No, no, no. Anything else? So, any guesses? Right. So let me tell you. Right. So historically, from the past 1,000 years, right? If you look at the history of the Indian subcontinent, you're gonna see one thing, right? There were a lot of people that were present in this region, right? So the people were very high and the food was very low here, right? So the most amount of famines were present in this place, right? The most amount of famines were present in this place. There was the greatest amount of malnutrition was present in South Asian countries and the Indian subcontinent. India, Pakistan, Bangladesh, Sri Lanka, Nepal, Bhutan, all of these regions, right? So since the famines were maximum here, we were having hypoglycemia, right? And guess again, which hormone comes back here? Any guess?
Growth hormone.
Growth hormone.
Yes.
Growth hormone.
So these patients had increased amount of growth hormone, right? And hypoglycemia also caused secretion of cortisol as well. And it's also caused secretion of epinephrine as well, right? In order to combat the famines, right? So genetically, we got these three things high. And as a result, our insulin resistance was very high in the baseline, right? Now we already have high baseline insulin resistance due to the famines that were going on for the past 5 or 6 for so many times, right? So what happens is that our body thoughts, so the bodies of our ancestors, all of the patients that lived in the Indian subcontinent, they came to know that these patients, that we are not gonna get food, right? We are not gonna get food. So what did the body decide to do? The body, so when, so remember I told you that why do we need glucose? We need glucose because our brain needs glucose, right? Brain can only use glucose. That is very important. So brain wants everything for itself. The brain is very bad. It only thinks of itself, right? So the brain thought I need a lot of glucose. So what am I gonna do is that if insulin comes and insulin acts on the cells, right? So if insulin comes and insulin is going to act on my cells, the glucose is going to decrease. And when the glucose is going to decrease, I'm going to have increased amount of hypoglycemia and maybe I won't survive. So for the survival instincts, our body increased our insulin resistance. And when the insulin resistance of the bodies were increased, as a fact, the glucose levels were increased. So now we had hyperglycemia. So basically, the diabetes was a survival mechanism in this area. The diabetes was a survival mechanism. So this diabetes that we have as a gift today is a survival mechanism by due to the famines. So a lot of people survived due to this hyperglycemia because the brain was working properly, and you need your brain to do all of the things, right? That is what our brain thought. But all of the famines have gone, but it's still these evolutionary traits stay with us. These things are known as the epigenetics, right? Yes. Yes. Yeah. Any questions? Yes, exactly, Dr. Akshay. It has to do with the chronic fasting stages in the past. So whenever you do chronic fasting, the insulin resistance is going to increase, right? Uh, Yes, it can be good, right? It won't be the same, but it's gonna be very good, right? So if you compare the diabetic control of a patient who has good diabetic control, statins, SGLT2, GLP-1 analogs, that patient is gonna be very much similar to a patient who does not have diabetes, right? To a normal non-diabetic patient. But it's very hard to do that, right? It's very hard to have a good diabetic control plus the use of statins and SGLT2 and GLP-1 analogs. Personally, I believe that they are very depressing to use, right? They are very depressing to use, right? So one thing regarding GLP-1 analogs, let me tell you one thing regarding GLP-1 analogs. So GLP-1 analogs, so we have a nucleus in our brain that is known as the dorsomedial nucleus of the hypothalamus, right? So we have a nucleus in the brain which is known as the dorsomedial nucleus of the hypothalamus. And dorsomedial nucleus of the hypothalamus controls our appetite, right? And this is the reward center of the brain. So some scientists call it as the reward center of the brain, because whenever this is activated, we are going to get a lot of wishes, right? So this is the wish center of the brain. And this is going to ask all of the wishes to us, right? So when this system is activated, we are going to get appetite, right? Whenever this system is activated, we want to go for shopping, right? Whenever this system is activated, we want to get good rewards, right? We want good things for ourselves, right? We want the best clothes when this system is activated, right? Right? We want to eat ice cream, we want to eat good things when this system is activated, right? All the sexual desires, all of those things come from the dorsomedial nucleus of the thalamus, right? So now what is going to happen is that now the scientists discovered a drug which was known as a GLP-1 analog, or the Ozempic. So what does the Ozempic do is that Ozempic is going to act on the dorsomedial nucleus of the thalamus, right? And as a result, it's going to control all of those wishes, right? So the patient, so one patient who is on the GLP-1 analogs, that patient is not going to have any appetite, but it's not going to suppress your appetite. It's going to suppress all of the other things as well, right? It's going to suppress all the other things as well. Right? It's going to suppress your wishes for shopping, your wishes for rewards, your wishes for doing good things in life. Right? All of those things are going to be suppressed with the help of a GLP-1 analog. So that is the side effect that GLP-1 analogs have, right? GLP-1 analogs make the things a lot more depressing. Now let's start type 1 versus type 2. So in case of type 1 diabetes mellitus, type 1 diabetes mellitus is autoimmune, right? So what is going to happen is that the cells are going to attack the pancreas are going to get destroyed, and you are not going to have any insulin, right? Type 2 diabetes mellitus occurs due to insulin resistance, right? Type 2 diabetes mellitus is going to occur due to the insulin resistance. There is going to be insulin resistance, and then the body is going to secrete more amount of insulin, and one time is going to send that the beta cells, and the pancreas is going to fail, right? Type 1 diabetes mellitus, you need for the treatment, you are going to need insulin, right? And type 2 diabetes mellitus, especially with the recent advancements in technology and medications and all of the stuffs, you do not need insulin. So most of the patients can be treated without insulin if the patient is having good control over the diabetes, right? Now, type 2 diabetes is present after the age of 40. Type 1 is present below the age of 30, right? So this is going to present in the young patients, and type 2 is going to present in older patients, right? Now, type 2 has a relation with obesity. Type 1 does not have a relation with obesity, right? And again, uh, glucose intolerance is going to be higher in type 1, it's going to be lower in the type 2, right? And now insulin resistance is going to be high in type 2, and it's going to be low in type 1, and insulin sensitivity is going to be opposite. All right, now we have two topics left behind, and that are the DKA. So the topic that are left behind is the DKA, and the next one is hyperosmolar hyperglycemic state, right? And we are already over our time, and I do not I do not want to rush over these topics, right? Right. I'm not gonna rush over these topics, right? Why? Because these topics are very important, right? So maybe let's do another topic, right? So let's do the toxic adenoma. Let's do the toxic adenoma. So we were doing hyperthyroidism, right? And in hyperthyroidism, we were done with all of the other topics. So now we are going to do toxic adenoma. So what is toxic adenoma? So toxic adenoma is very simple, right? So if this is the thyroid and this is the thyroid, we have follicles here, right? And these follicles need the TSH to activate, right? But what is going to happen sometime is that some of these follicles are going to get autonomous, right? These follicles are going to rebel, and these follicles are going to say, we do not need any more TSH, right? These follicles are going to say, we do not need any more TSH, right? And they're going to work independently, right? So the T3 and T4 are going to be increased, right? The TSH is going to be decreased, but there won't be any kind of autoantibodies that are going to be present here, right? So there won't be any autoantibodies that are going to be present here. Okay. Insulin resistance. Okay. Okay. Now, okay. So we can start tomorrow from the insulin resistance, right? So we're going to do the insulin. So there's a graph here in first aid, right? What I'm going to do is that I'm going to explain this graph in detail tomorrow, right? And this is going to tell you a lot about the insulin resistance, right? So my plan is that whenever we do the endocrine, whenever we do any systems, I'm yes, yes, the radioiodine uptake is going to be high, but don't worry. Well, I'm going to go over the detail of radioiodine uptake tomorrow, right? I'm going to go into detail about it. Yes, sir. So my plan is that I'm going to teach you all of the biochemistry in these systems as well, right? So whenever we do the systems, I'm going to do the biochemistry as well as much as we can, right? So this was it today, right? So guys, do have happy learning, right? Have a good day. And tomorrow we are going to start the day 5 topics as well as the hypothyroidism and the diabetic ketoacidosis as well as the hyperosmolar hyperglycemic syndrome. Okay, guys, take care. Bye bye. Right.